Assalamu alaikum. It is a case of Percutaneous Cystolithotomy once again. This is the findings of the flexible cystoscopy. You can see that the bladder is almost full of stone. The wall here of the bladder is quite different than from the other patient that we discussed in the previous video. Here the prostate's median lobe is enlarged and the wall is very thick, and there are multiple trabeculations and diverticuli, albeit small ones, but they are present in the bladder. Here the patient's age is around 70 years, and he had a road traffic accident where he lost one leg. He had above knee amputation, and he made this stone. So this is the puncture suprapubically under vision, and we placed the guide wire, and then the Seldinger technique will be used. We remove the needle, and then we place a facial dilator of 6 FR to dilate the tract a bit, and over that we place a olive tip dilator of the same Alkan's dilators that are used for the percutaneous nephrolithotomy. It is a serial dilatation and telescoping of the dilators one after the other. So slowly and gradually the increasing size of dilators are passed, and once we are through with all the dilators available, be that 26 FR or 28 FR, then we can place the implant sheath, and a standard nephroscope will then be used suprapubically to do the cystoscopy, and then fragment the stone with the pneumatic lithoglast, and then retrieve the pieces. So here the largest dilator has been passed, and now implant sheath is about to be passed over the Alkan's dilators. Here you can see, and then we go to the tract suprapubically with the standard nephroscope and its lithoglast. So the indication of Percutaneous Cysto Lithotomy or lithotripsy or lithoclasty in this case was that the patient was having amputation, above knee amputation of the right leg, and he also had a spinal fixation due to road traffic accident years ago. And then this patient developed severe lower urinary tract symptoms with frequency, urgency, nocturia, severe pain in the suprapubic region, and then hematuria. So when he was investigated, he was found to have a large bladder stone around 6.5 to 7 centimeter, and also a prostate of around 80 grams. But on cystoscopy, we saw that the bladder neck was a little bit open. However, the prostate was occluding, especially the lateral lobes. But through the tract of the suprapubic region, and with the nephroscope, we'll be seeing that the bladder neck is quite high, which may be the cause for stone formation. Plus, the patient is not very much mobile. Sorry. Leading to recurrent urinary tract infections and hence formation of the bladder stone. While fragmenting the stone, it seems to be extremely hard, and it took a lot of time to fragment the stone. So not an easy stone to be fragmented. Having the enlarged prostate, it was very clear that it could not be dealt with perurethral, the stone. So something different had to be done. One way of doing this is by doing a vesical lithotomy, and at the same time doing a transvesical prostatectomy. But as transvesical prostatectomy has got its own morbidities, the patient was reluctant to undergo an invasive procedure for his prostate. So we agreed upon doing his procedure in two stages. In the first stage, we'll perform a percutaneous cysto lithotripsy and clear his urinary bladder off the stone. And then after 3 to 4 weeks, we'll perform his transurethral resection of prostate. So this is the first stage now. It can be seen that the stone is really hard. And the bladder is not as friendly as it was in the previous video of cystolitholapexy. However, we have got a pneumatic lithoplast which can fragment. So here many small fragments will be formed, which will be difficult to retrieve with the forceps. So we will use pressure wash from suprapubic tract as well as from the perurethral tract through a perurethral catheter, so that the fragments can be retrieved suprapubically. So there are very minimum number of indications left for the open procedure for bladderstone nowadays, because it can be done perurethral, it can be done suprapubically by percutaneous route. Of course, the morbidity of the percutaneous approach is very much less than vesical lithotomy or open vesical lithotomy. The second thing is that his prostate was enlarged and occluding, but it was within the range of transurethral resection. If it was more than that, like for example, if it was more than 80 grams according to the guidelines, or if it was more than 120, 130, 150 grams, then anyways he would have required an open procedure like Millen's prostatectomy or a transvesical prostatectomy. So in that case, a vesical lithotomy would have been the preferred choice. But since his prostate can be dealt with transurethral with the resection, that's why we decided to perform the stone clearance through percutaneous route. Here, every now and then, when the stone is removed, we are able to see the bladder wall from the inside. You can see that there is severe hypertrophy of the mucosa, and there is inflammation, and there are small diverticuli, severe trabeculation, and also in a while we'll be able to see the bladder neck from the inside, and it will clarify the high bladder neck as well as the median and lateral lobes of the prostate. Here we are not using the forceps, as you can see. The simple wash from below perurethral through the catheter is pushing all all the stones through the suprapubic route outside the bladder, because they are so small and there are so many that going in and taking them out one by one would take all day. Anyways, this procedure took us around 1.5 hours, and that was because of the hardness of the stone. So a good wash from below and a good pressure from above in the nephroscope will make the bladder filled, and the only way through which the fluid will be escaping will be the suprapubic route. So the stones will follow the fluid and hence they will be cleared from the bladder. So in the percutaneous suprapubic route, we place a 2-way or a 3-way catheter for 1 or 2 days, just in case if there is blockage of the perurethral catheter and there is leak in the suprapubic region. So this catheter is a good way. It's not necessary, but it's good to keep this place intubated. And removal of the suprapubic catheter is usually advised on the first post-op day or the second post-op day. So we remove the suprapubic catheter on the first post-op day if there are no complications, and then we discharge the patient on the first post-op day or the second post-op day as the need may be. So one large piece which would not come out through the suprapubic route is present, and that is being fragmented now. And a removal of the perurethral catheter will depend on the indication of the procedure, the presence of urethral stricture or the presence of any bladder outlet obstruction in the form of enlarged prostate. Here you can see there's small diverticuli as well. There is some slough lying here and there. You can see the median and the lateral lobes of the prostate as well. And then we'll place a perurethral catheter under vision, and that will be it. Thank you for watching the procedure, and please do not forget to subscribe the channel. We have a motto of promoting positivity, promoting knowledge, and promoting skill. Thank you very much.